So now let's move on to premature ventricular contractions. And we looked at the other premature contractions. We have premature atrial contractions, premature junctional contractions, and now we have premature ventricular contractions. So in what's happening on all of these, they are occurring before the next expected beat. They're occurring early, before you want them to. So premature complexes are occurring before the next expected beat. So with these premature beats, we're going to look at, so when you go for rhythm interpretation, you want to look at the overall presentation of the rhythm. We want to decide, we need to determine, is the rhythm regular? What the rate is? Do we have P waves? Do we have QRS complexes, etc.? So in this case, we're going to look from a number of these complexes, look at this top one. So overall, the rhythm is irregular. And we're going, okay, so we recognize it's irregular, and then we need to figure out where is it irregular. So if we can take a moment to figure out, well, there's some irregularity here. So I'll figure out from that way, this is regular. So what are these complexes? So what's normal, what's abnormal? And we can say that this is abnormal, and we're going to look at a couple different viewpoints here. So in this case, we have upright P waves QRS, upright P wave QRS, upright P wave QRS. So by definition, we can say that, and based off a rate, we can say that this is a sinus rhythm. At least these are sinus complexes. When we get here, this P wave looks a little bit different than these other ones. It's more pointed and spiked. Our next expected beat should have occurred somewhere right around in here. So this complex occurred early. We have an upright P wave. It does not look like our normal SA P waves or sinus P waves. So upright P wave, it's early. So we know this is a premature contraction. With upright P waves, that tells us that it is an atrial complex. So in this case, this is a PAC. Looking at this next option here, same thing here. These look regular. Upright P waves, QRS, rhythm is regular. So by definition and by rules, we're going to say this is sinus rhythm. However, we're dealing with this abnormal complex here. Our next complex should occur there. So we have a downward P wave, narrow QRS. So if you remember from junctional rules, junctional rhythms are going to have absent or inverted P waves. So in this case, we have an inverted P wave. It's occurring early before the next expected beat. So this is premature. Now we have identified as a premature beat. Now, is it an premature atrial beat, premature junctional beat, or premature ventricular beat? So in this case, we know it's premature, it's inverted P wave, so that makes that a PJC. Looking at our last example here, same thing, we've identified the first part of this, or there are some sinus beats. So this is sinus rhythm. So what's abnormal here? Still we have this abnormal beat there. So it's occurring before the next expected beat, should be right there. So again, it's premature. It's a wide, bizarre looking complex. Do not see any notable P waves that precedes the QRS complex. So that, by definition, is a PVC. And we see another PVC here. Here's another PJC, and this one's actually missing a P wave. So absent P wave, and here's another PAC that we have there. So how do you recognize PVCs? Well, somewhat just mentioned that. You want to look for wide bizarre complexes. The PVC, excuse me, is premature, so it should occur before the next expected beat. But in a couple of cases, we have different variations of PVCs, and the PVCs often may look different. And it depends on where they're originating from. If they're originating from the same atopic or irritated side in the ventricles, it's going to, for the most part, be the same shape and size. So we can have some varying differences too. So you may have a PVC that makes a rhythm. Obviously, it's a PVC that's making it irregular and all, but then we have compensatory pauses or incomplete compensatory pause. So a full compensatory pause is going to wait until the heart's ready. So we have a discharge or a PVC. It sends a signal out. So now, even though it's early, the heart's having to go back through repolarization. And then, so it's basically waiting for the next rhythm, the next cycle for the SA node or the underlying rhythm, in this case sinus. It's waiting for its next impulse from the SA node. So you may see a prolonged difference between the PVC and the next complex. So a fusion beat is another consideration for a PVC. So basically a fusion beat is you have two impulses trying to travel whose opposite ends traveling to the same place. And that would give you a fusion beat. So in this case, we have an electrical impulse from a supraventricular site, such as the SA node, firing at the same time as atopic site in the ventricles. So what's happening in this case, this is our heart, SA node. So SA node is firing, and then we have an atopic site somewhere in the ventricles that's trying to fire also. So when these two kind of meet, we don't get a full depolarization or a full normal looking QRS complex. What we get is something in that case. So basically you have, in this case, we have a P wave. When you see the P wave and the atrial is depolarizing, and the ventricles are coming back from this case. So basically you have two independent stimulus. So you have the SA node and you have the side in the ventricles that's both simultaneously or sending the signal. So we have the P wave represents atrial depolarization. We have this, again, abnormal looking QRS. It doesn't even look like a normal PVC. So that's the fusion beat. So PVCs are usually identified in a couple different ways. One, you may have uniform PVCs or unifocal or uniformed, meaning they're all the same shape, one form, one shape. And unifocal meaning they're coming from one side in the ventricles, or usually the same side. You may have multifocal or multiformed. So multiformed being they're in different shape and sizes, and you may have same as multiform is multifocal, meaning they're coming from different atopic sites in the ventricles. So with PVC patterns with these, we have other terminologies is pairs or couplets. This is where you have two PVCs in a row. So you may have normal rhythm, normal beat, normal beat, normal beat, PVC, PVC, normal beat, normal beat. Runs or bursts are three or more PVCs in a row. Bigeminal is you have every other beat is a PVC. With trigeminal, every third beat is a PVC, and quadriminal, every fourth beat is a PVC. So I mentioned uniform PVCs, and so this is an example of uniform PVCs. So if you see this PVC here and that one, notice how they both look the same. So they're uniformed and they both look alike and usually originate from the same anatomical location or atopic site in the ventricles. As far as a multiform PVC, they appear different from one another. You can see this PVC there and this PVC here versus that one, and how they are difference in opinions, or difference in shape, difference in size. So that is considered a PVC, multiform PVC. Then we have interpolated PVCs. So interpolated or squeezed between two normal complexes. So with a PVC, it does not change. If you were to take this PVC out with interpolated PVCs, it does nothing, does not make the rhythm irregular. Because we do not have that full compensatory pause. If we're dealing with a compensatory pause, that next complex should occur somewhere here. In this case, the interpolated PVCs are squeezed between two regular complexes without a compensatory pause. So therefore, it doesn't disturb the underlying beat. Like I said, if we were to take that out, the rhythm would remain regular. Then we have R-on-T PVCs, and R may be known as, some of you may have heard as R-on-T phenomenon. They occur if the R wave of the PVC falls on the T wave of the preceding beat. So in this case, here's our P wave QRS coming in our T wave, and just as it comes up on our T wave, we have QRS complex occur. And another example here, same example. So we have our coming in on our T wave, our PVC occur, and that's R-on-T PVC. One of the biggest problems with these, I say it's a big problem, is sometimes they can trigger, since we're messing up now, we're kind of, with that PVC occurring at the time of the T wave, we're start messing up with the conduction system, start messing up repolarization. That mix up and repolarization can trigger VFib or VTAC. So here's two PVCs in a row. Again, going back, definition known as couplet or paired PVC. So here's our couplet PVCs there. 3 more PVCs in a row are, if they're saying it's a rate of 100 or more, then that's run or a burst of VTAC. So how do you recognize a PVC? Well, first and foremost, PVC is not a rhythm, it's just an atopic beat that is occurring. So one PVC alone is just an atopic beat, it's not a quote-unquote rhythm. So the PVCs, so when we're saying what's the rate of the rhythm, we're saying what's the rate of the underlying rhythm. Usually it's within normal limits. With PV, and the rhythms probably, again, depends on the underlying rhythm. Now, if you have AFib is irregular, irregular unless it's controlled. So you have an irregular rhythm. You have a PVC, so the rhythm's already irregular, so PVC in there is still making the rhythm irregular. Unlike sinus rhythm, and with thrown in PVC, it makes the rhythm irregular. So the rhythm's going to be dependent on the underlying rhythm. So we talked about how the PVCs look. PR interval, P waves, and PR intervals do not exist with PVCs. Now, if you remember back from junction rhythms, how you have retrograde retrograde P waves. The same thing would have happened if we have an atopic site in the ventricles decides to stimulate the contraction. So the impulse is still traveling up toward my right shoulder, It's still following the same pathway. Once he hits a bundle of his, it's going back to the AV node. It's still sending that signal back to the atria. So you may see a P wave, but that P wave is going to be absent, or it's going to be inverted, or that P wave may be hidden in the QRS complex somewhere. But one big recognizing factor with PVCs is the width of the PVC. So PVCs are normal. They happen in healthy people. However, the incidence of PVCs increase with age. 1 or 2 PVCs does not matter. You know, I probably have some every day. You probably have some every day. So, but the problem is how frequently are they occurring, and how quickly are they occurring. Then again, then you're dealing with is the R-on-T phenomenon that you got to be concerned about. So really what causes it is normal. Hypoxia may cause it. You see these other examples here. Certain medications may, stimulants, acute coronary syndrome. So if you have an area of the heart that's hypoxic, your hypoxic muscle becomes irritated. Irritated muscles may send off a signal due to that irritation, and it may cause a PVC. What do you want to do about it? Really depends on is it causing problems? What's the underlying rhythm? How frequently are they occurring? Etc. So patients may be asymptomatic and may have no symptoms at all, may not even realize they have it, or they may be just complaining that, well, it feels like my heart's flip-flopping, or feels like my heart's skipping a beat, etc. Or it may actually cause chest pain, and it depends on how frequently they are occurring. If PVCs are frequent with signs of decreased cardiac output, you may need to treat. So then you don't have to, only way to treat PVCs when we could try oxygen if hypoxia is suspected. If it's suspected the patient has a myocardial infarction, acute coronary syndrome, then also we would treat those through protocol. Or if they're really frequent, we may need to go to something like lidocaine or amiodarone to help slow those PVCs occurring.